Now this is a hematogenous infection which is showing the green color here, not the usual color for the hematogenous. It will go to the various organs. It could be any organs, like it can be brain, it can be kidney, it can be mesengium of the kidney, it can be meninges, bones, and they produce small tiny granulomas as well in those organs. In that case we are calling it a systemic miliary tuberculosis. So miliary tuberculosis can be two types. One, it could be the pulmonary specific, and in that case the granuloma is spreading via lymphatics, and there is a systemic miliary tuberculosis when the granuloma is spreading via hematogenous route. So you see some pictures. Is a classical picture. On your right hand side you can see a nice cavity of the progressive secondary pulmonary tuberculosis. You can see cavity at the apex, and you can see the miliary tuberculosis on your left hand side. You can see small tiny miliary lesions which is via lymphatic spread. Then once again you can see a nice caseation on your left hand side, epithelioid cell and lot of giant cells of a caseation granuloma. This is what is the flow chart of the progression of the secondary progressive pulmonary tuberculosis. You can see the erosion of the bronchus due to a progressive granuloma. Then it can invade the lymphatics, or it can invade the blood vessels. If it is eroding a bronchus, it can release the caseation in the bronchus. Then it can it can cause a seeding to the trachea and bronchus as the patient is trying to cough it out. And you know that this caseation contains a lot of bacteria, so that can produce a tracheal seeding. At the same time, if the granuloma is trying to invade a lymphatics, it will produce a miliary tuberculosis, which is classically pulmonary location. Means lymphatic spread can be limited. If it is a vascular disseminations, then in that case this miliary tuberculosis would be systemic. Patient can have a hemoptysis. You can see the patient is coughing out blood. It means the infection now has eroding a blood vessels, which is very dangerous. This is a nice picture of a miliary appearance. You can see very tiny faint yellow colors. It is called miliary because it is very tiny and small, like a millet seeds, very tiny granulomas. All these things you can see very tiny and small yellow things, they are all the small tiny granulomas. So if it is a miliary involvement of the lungs, it is basically, what is the mode of transport? Anybody can tell? Lymphatics. But if it is a systemic miliary lesion, then what is the mode of transport? Yes, you got it. It is the hematogenous. Why it is known as miliary? Because the granuloma is very tiny and small, and they look like a millet seed. So this is a clinical course which I already discussed with you. Very low grade fever, remitting type, night sweats, very important, malaise, anorexia, weight loss. So can you tell me any other disease can have this kind of clinical feature which can mimic a tuberculosis? Yes, somebody says sarcoidosis. Did you say sarcoidosis? Yes. So sarcoidosis is number 2 condition when you can get this kind of clinical features. Can you tell any other disease apart from sarcoidosis can produce these conditions, these clinical conditions? No one? Remember, Hodgkin's lymphoma or Hodgkin's disease also can produce this kind of symptoms. So how to diagnose this thing? Tell the patient to cough out some sputum, make a smear, and do a Ziel-Nielsen stain, that is the acid fast stain. When you do the acid fast stain, you can see this pinkish or red color bacillus. And now sometime we do the PCR amplification for the diagnosis of Mycobacterium tuberculosis. Suppose the patient has AIDS, AIDS. In that case, what is the agent? Is it a Mycobacterium tuberculosis? No. It is a Mycobacterium avium intracellularly. That is the agent who has a tuberculosis and the patient has AIDS infection. So PCR amplification can identify even there is a very few bacillus present in the sputum. We can also do the skin test, Mantoux skin test. We discussed about the negative tests. When the patient has an overwhelming infection or sarcoidosis, this test can be negative. I want you to listen to my lecture on sarcoidosis to understand what is energy and how it is developed. So also remember, if the patient has an overwhelming tuberculosis, this skin test to identify tuberculosis also can be false negative. So is there any chance that patient have a false positive test? Yes, that is the atypical Mycobacterium infection. In that case, the patient can have a false positive tuberculosis test. So this is atypical, very important, and this is becoming very common in the United States. Mycobacterium avium intracellularly, Mycobacterium kansasi, and they are very common. They mimic the typical tuberculosis in presentation, and they are very typically common in the upper lobe, producing the cavitary lesion. So I want you to make sure that you remember this is becoming a very important agent in United States which can produce a tuberculosis infection. So what are the risk factors for this atypical tuberculosis disease? COPD, cystic fibrosis, and pneumoconiosis. Which pneumoconiosis has got affinity for tuberculosis? Can you tell me that? It is the silicosis. So the clinical course of this atypical tuberculosis is very similar to the classic tuberculosis, but it is more aggressive. Why it is more aggressive? Because the atypical tuberculosis you commonly see in a patient who has a severe immunosuppression. That is why it is more dangerous. So I hope that you understand something about this lecture. So what you are supposed to study, let me revise or summarize it quickly. You should know what is the mechanism of formation of a granuloma. You should know what kind of granuloma you can see in tuberculosis. You should know what is the name of the agent that produce tuberculosis. What is the name of the agent if the patient has AIDS infection. You should know what are the agents causing atypical tuberculosis. You should know what are the features of primary tuberculosis and how you can diagnose it. You should know what are the features of secondary tuberculosis and how you can diagnose this one. So naturally, primary and secondary tuberculosis are the two most important issues that we have to work on it. How to diagnose secondary, how to diagnose primary. If it is a primary, which are the organs commonly involved? If it is a secondary, where you get the infection first to occur in the lungs? Can you tell me where it can occur in the secondary tuberculosis? Yes, you get in the lung, the apex of the lung, where it often produces a cavity. Lastly, we should know what is the miliary tuberculosis. What is the concept? When we get the miliary tuberculosis, where we can get it? We can get only in the lungs, and also we can get in the systemic organs. If it is in the lung, what is the mode of transport, or how do you get it? If it is in the systemic organs, how do you get it? So I hope that you enjoyed this lecture, and please study these questions that I already asked you. I hope that you have a very nice study break. Thank you.